I want to preface my presentation with the fact that my professional relationship with health data is relatively new. So while I'm here as a presenter, I'm just so humbled to have the privilege to attend today's forum and learn from the various presenters and panelists. My background is social work. I've spent the last 20 years in various areas of human services, primarily within the Northwest Territories. And I will first start out by introducing you to the organization that I work for. So the NTHSSA is the main governing body responsible for delivery of health and social services across 5 regions and 27 communities in the NWT. So it covers a geographical area of approximately 1.2 million square kilometers. So earlier you've heard different people mention about isolation, geographic complexity. So we are one of the most complex territories of all when it comes to that. The authority was created through amalgamation of the regional authorities in 2016 with the aim of improved service coordination, patient care, overall efficiency. The overall staffing complement is approximately 1,800, and it also serves as a lead to the other 2 health and social services authorities. And overall, our organization is still very young. We're very much in our infancy, and we're only celebrating our 10th anniversary this summer. So we're really just starting our deliberate data journey. So, as I said, fairly new to my professional journey with data. Last summer, I made a major career shift, again, working across different areas of human services into corporate support services. One of the first priorities and tasks was for me to develop a dashboard for a health authority, which may seem not very big for many of the large health authorities and organizations across our country, but was pretty significant for our particular jurisdiction. One of the main driving factors for the dashboard was to create a mechanism to engage the public and to improve our overall transparency and accountability to the communities that we serve. So while I was truly excited by the overwhelm was significant to say the least. So to put it into context, we have 0 data type positions within our organization. So we didn't even have a data analyst. So I was a bit lost on where do I start, and I knew that supports would be necessary. So we partnered with a small company, and actually Jonathan, the previous presenter, may be familiar with them. It's a small firm in the Northwest Territories called Triage Metrics, and they're actually doing some work in Nunavut as well. They work primarily in healthcare, and their CEO and chief health economist, Scott Robertson, has a ton of experience. So I'm super grateful for Scott and his team and all of their support in enabling us to move this work forward and to have a starting point. So we're very much aware that to start with a dashboard as a first step was quite unconventional, as typically you would ensure that you have all your foundational pieces in place, you have your data strategy, your governance, your resources. But I guess, too, sometimes you can get away with doing things a little bit differently in the North. Also, the challenge really is that within the complexity of our system, we had to have a starting point. If we waited for all of these other components to be in place, the barriers would just continuously prevent us from starting at all. So in reality, the dashboard provided a jumping off point, as now we had something concrete, and it highlighted what was possible as well. Like all health systems, we collect a huge amount of data in the course of frontline service delivery, but that is needed to ensure patient safety and continuity of care. But without proper data management or data quality capabilities, our health system has been unable to monitor, cleanse, and organize our data for other secondary uses. So as the first step, Triage Metrics started with an inventory of data assets to understand what we were collecting and how the data flows through our systems. And then this process, through it, we uncovered significant data quality issues, including missing data, duplication, et cetera, et cetera. We suspected there was likely over-collection of data, of course, lack of governance rules, and overall poor documentation. The context, so I've kind of touched on this already, but I certainly don't want to minimize the impacts when it does come to the Northwest Territories and the geographic, demographic challenges, our siloed and fragmented data systems, the cultural and ethical considerations that we've touched on, I've heard different presenters touch on significantly today, and of course the criticality of context-driven design. So any discussion of health data in the territory has to be grounded in context. There's many challenges, you know, when I know folks have mentioned earlier, the vast geographical considerations, you know, many of our communities are not accessible by road at all, so they're fly-in only. And this really does impact our data journey from everything from data collection, timeliness, to statistical reliability and privacy considerations. Small numbers, of course, make trends harder to interpret, and we have like just basic considerations like, you know, we don't have reliable internet connection even in some of our communities. So these are all things we need to take into consideration. The system itself, I won't go into this too much, but of course, you know, really old platforms, legacy ones, when it comes to interoperability, that's like a dream for us. Again, just the siloing of data is really a huge problem for us. And then, like, again, I'm not going to go too much into the criticality of Indigenous data sovereignty, but just due to I only have a couple of minutes left, so I want to be respectful of others' time. But I just want to speak to the fact that I know how critical it is, and that that is not something that will be minimized or you know, missed. That's something that we would dismiss in our journey whatsoever. Oh, that doesn't. So. Our dashboards are public, and THSSA, if anybody wants to go onto our website, for our first dashboard, we did do a release. We focused on 6 indicators. These are not necessarily, you know, the critical KPIs that we want to focus on. However, we had to start someplace. And so this did enable the public to see our information, as well as, I would just say one of the highlights of this work is the rise of data champions. The staff could see the data, they could see that what they were doing is visible, it validated things. One particular area was lab volumes. We were having significant public criticism, even myself, you know, you can't get into for lab to do your, you know, blood work even. It's taking, you know, 3 weeks, what have you. So this was validating for us, for the staff, for the public, because they could see how much the volume had increased, so that direct linkage. And again, lots and lots of other challenges, which I'm willing to chat with others about as we have a few minutes here left at the end, and if we get questions. The last few slides here, it's just really moving from dashboard to data strategy. So, of course, we never intended to just do the dashboard, but we needed something for a catalyst. So it was our entry point to have something concrete to be able to see, share our data. So next steps are really going to be strengthening governance. That's going to be critical, building analytics and establishing data management functions. Again, while this whole kind of exercise and project at the beginning was daunting, I think with the partners that we have through Triage Metrics, HOTACITA, HRDN, and of course our own staff and ministry champions, I do kind of end this with optimism that we can move these priorities forward.
Hi, thank you everyone for having me here today. My name is Conrad Pow. I'm the senior lead, as you heard, of digital health at Diabetes Action Canada. I don't have any financial disclosures, but I do have to say that my youngest daughter lives with type 1 diabetes, and she does receive financial support for Dexcom to be part of some of their media campaigns. So if you look on TV, you might see her jump up on a slide or something like that. So I'm here to talk a little bit about the work that we do at Diabetes Action Canada. In a nutshell, we are a research network. We bring together patient partners, researchers, policy and decision makers. All of our work is co-designed with patients embedded not as advisors, but as actual participants and decision makers. We have the nation's largest patient partner network, and they are involved in the governance, implementation, in the different partnerships we do, and they help frame our research priorities. For our research, as you heard, we focus on primary care EMR data. So how can we use this data in order to create risk calculators or to create some sort of system that helps us identify individuals who are not receiving optimal care so we can intervene sooner. We are also a national leader when it comes to patient-oriented research, where our platforms have been adopted internationally and downloaded over 100,000 times in over 130 countries. Now, at DAC, we didn't start with a database, we didn't start with research projects. We actually started with a conversation with our patient partners. We wanted to know what fears do they have and what do they want. So they basically told us they wanted greater control of their data. Who's using it? What are they using for? What are the outcomes and where does the actual results go? They also told us their greatest fears: diabetic retinopathy, so blindness, and lower limb amputation. And so I had to transition from the research hat to a dad, because I was thinking, you know, when Chloe gets older, is she going to have these same fears? Blindness, limb amputation. So that kind of drives me, and it's these personal connections and personal stories that help push our research priorities. And so from that, we created a project called Project Open. So this project was done with ICS and the Alliance for Healthier Communities. So they have the data from community health centers. So this is the very marginalized and vulnerable populations. We wanted to see, can we look at individuals who have not had preventative retinopathy screening in the past year and a half, flag them, schedule them for an eye exam, and if they are overdue, they can actually go and get it done. In Ontario, our data is fragmented. Optometrists and ophthalmologists can perform the screenings, but that information doesn't flow into the EMR. So a family physician has no idea unless they invest time and search to see whether or not a patient has done it. But this is where the issue happened, because even though we could identify these individuals, we had a problem, because we had to re-identify a de-identified cohort list. And then we had to ask for this list to be exported into clinical care for direct patient contact. So for all the privacy folks, that's a big no-no. However, with the assistance of ICS, who was instrumental in this project, we petitioned the Information Privacy Commissioner to allow us to re-identify a de-identified cohort list, flag individuals, and send this to the Circle of Care for a direct patient contact. We finally got approval. COVID hit, so that kind of screwed things up for us. But regardless, we were able to identify out of 3 CHCs over 4,000 individuals who were overdue for screening. Of them, we consented and contacted 1,600. 400 of them completed the screening. They wanted to participate. And 1 in 3 already had diabetic retinopathy. So we now found this invisible population who was going to be missed by the system, and we found who they are, and we got them the screening. Layered on top of this, we worked with a health economist out of the University of Toronto to do a health economic evaluation, and found that for every $1 invested in screening uninsured individuals, we saved the Ontario government $27. I'm happy to say that this caught the attention of Ontario Health, and we are now working on Ontario Health to create a provincial-wide screening program that follows the abdominal aortic aneurysm screening platform they have. Another project is called, well, we call it the LARP project, the Limb Amputation Risk Prediction Tool. So this is a project that we did with St. Mike's, Unity Health, the Vector Institute, Gemini, and this one doesn't work, and the Downtown Toronto East OHT. So in this project, we wanted to see, can we flag individuals who are at a risk for a future foot complication we found that a high majority of individuals who had an amputation were hospitalized a year before. So this is a missed opportunity we can use at a hospital. So a tool was created, and it uses routinely collected discharge abstract database information from a hospital. When a patient is discharged, it goes through this calculator, and they're flagged as either high, moderate, or low risk. And it basically gets triaged, the individuals gets contacted, and they're sent to community supports. Right now, we are expanding this to 2 hospitals in Ontario, and we have the support of some of the CHCs in order to put this through their foot care clinics. So again, I'm here today not only as a researcher, but as a dad. And I think, with everyone here, I think we have a moral obligation to actually have this collected data that we have and use it for the best interests of patients, but in a meaningful way where patients are involved in the research, involved in the actual lay summaries that come out so they can understand it. And hopefully we can all make a change because they gave us the reason and we need to come up with the answers.
I'm here today to talk to you about the impact data is having on the health of people in Saskatchewan. And I want to focus on 3 ways that access to health data for research purposes is transforming health equity, healthcare, and the health system in Saskatchewan. And so I'm going to talk to you about the journey of the Health Research Data Platform Saskatchewan. So, health data in Saskatchewan is an abundant resource collected by the health system every time a patient sees a doctor, fills a prescription, has lab work done, etc. However, in Saskatchewan, as in many provinces and territories, there are multiple trustees for this data. And every time data is shared with a researcher or another health system partner for secondary use, a data sharing agreement is required. So, if a researcher wants to study the correlation between lung cancer, COPD, and smoking to help develop lung cancer screening guidelines, they would have to negotiate and sign data sharing agreements with 3 or 4 different entities, sometimes taking 3 years in order to complete. Similarly, if the ministry wants to study hip and knee surgery wait times and outcomes, they would have to negotiate data sharing agreements with other trustees in the system in order to receive this data to inform policy making. And so this system has made it very difficult to undertake research and quality improvement using health admin data in Saskatchewan. So this had, not just in Saskatchewan, but a sort of a bigger equity gap where the people of Saskatchewan were missing from national studies, with researchers often relying on data, sometimes from Manitoba, to inform observations in Saskatchewan. And having lived in both provinces, the healthcare system's delivery and population are very different, so it's not just a one-for-one. So to address this system and what we had, in July 2022, a master health data sharing agreement was signed with 7 health system data trustees that enabled the establishment of this Health Data Research Platform Saskatchewan. So the Health Research Data Platform, HRDP. And this is the first fully integrated multi-agency data access platform for research in the province. We have had over 110 consultations with researchers since that time. We've enabled a standardized process for researchers to request the data. The HRDP has 7 data sets, which is very small in comparison to other data centers. But what we do have is we have 18 research teams that have completed or currently analyzing data in the HRDP. So this is significant progress, I would say. And we have, because of this, there are improvements, I think, that are happening within the system. And one of them is the issue of health equity in terms of Saskatchewan data actually being included in national work. And so one example is the participation as a provincial site in the HDRN project that had essentially a request from Canada's Drug Agency to monitor and evaluate National Pharmacare program, specifically looking at contraceptives and diabetes medication. And so this, for us, is a really big win, where it is data from Saskatchewan that is actually being included, rather than just that data not being participate in the research projects. And so HDRN will continue to build capacity to participate in these studies, significantly reducing the equity gap for the Saskatchewan population. So another piece that is actually happening is that data in Saskatchewan is being used to inform policy in the province. So researchers in Saskatchewan have evaluated, using the HRDP, a chronic pain clinic. And they'd studied a number of items in this, and there wasn't a significant change in emergency department visits or physician billing within the first 6 months before versus after participation. But what they did find is that hospitalization rates significantly reduced following enrollment. And so these findings really do build on earlier results, showing that improved opioid management and increased patient engagement do support and have meaningful impact on both patient health and health system outcomes. And so these are two examples of projects where work that is completed in the HRDP is actually having an impact and moving to a knowledge mobilization phase. We have a number of other projects, which I won't get to, but so just to remember, we started in 2022, and we now have some projects that are now moving into knowledge mobilization. I think what we've also seen, by the existence of the Health Research Data Platform, there have been an increase in a number of clinician scientists that are wanting to do this work in sort of a gray area between research and quality improvement. And they have been, a lot of these projects have been, or with data that they haven't been able to access through the health system. And so now they're using the Health Research Data Platform in order to do that. And one of them was an evaluation of the spine pathway in the province. But what it identified for us was that there were a number of clinicians in the health system practitioners, and they had a gap in their ability to access the data. So what is actually happening now to try and address this gap? And I'll just sort of go through here. Oh, we've missed a section of it. The HRDP is actually being used as a model to build data access for the health system and create the health data platform. Via a provincial digital health strategy in Saskatchewan, there will be a central repository that is created whereby either for data science, for research purposes, business intelligence, quality improvement, there will be access to the data that is in the central repository, and the research will be one component of it. But I think the important thing for me is that it is being built on the foundation of this Master Health Data Sharing Agreement and all of the processes and capacity that we are putting in place with the HRDP. So, in conclusion, the health data access in Saskatchewan has been and continues to be transformed. The HRDP supports health equity and decision-making, enabled population-based data to be used in research, and is ensuring that the inclusion of Saskatchewan people in national studies. While it's still early days, the HRDP is enabling local research, which will improve the health system in the province. And by demonstrating its effectiveness, increasing data quality, and building trust within health system trustees, the HRDP will be the foundation of a system-wide transformation, enabling data access to support system changes and improve outcomes for the people of Saskatchewan.
I'll give you some highlights from both our Canadian seeking solutions to chronic kidney disease, the CanSolve CKD network, and also our provincial database at BC Renal Agency. And so what I wanted to share with you is how over the years we've been using data to impact patient care and outcomes. In BC Renal, using our database Promise, which I'll tell you about, this is a provincial database integrated with clinical information systems around the province, because British Columbia, like many other provinces, doesn't have any single system. In fact, every health region has a totally different system, even if it's called Cerner. It's Cerner 1, Cerner 2, and Cerner 3. And it's quite annoying in terms of trying to navigate this. But as Dr. Etier talked about earlier, perhaps it's an example of how you integrate information to get answers. And then how we actually use data to drive important research questions and answers in the CanSolve network. So PROMISE, it stands for Patient Records and Outcome Management Information System. Importantly, it captures all information in a longitudinal way about patients with kidney diseases and all solid organ transplants. And it touches every aspect of care. So it's used by and supports healthcare providers, program administrators, finance, national registry connections, and research. So it really is a one thing. You won't be able to see this, but this is the data sets, and that they're used, for example, for Ministry of Health funding and forecasting, transitions of care, clinical decision-making, emergency management and planning, reporting to CORE, quality and outcomes reporting, facility planning and projection, as well as provincial coordination and care. And importantly, especially during COVID, we were able to actually tell you where every single dialysis patient was, where the capacity was, who has COVID and how to segregate them and track what happened, who's been vaccinated and who hasn't, and the variability across and within regions. And we use that to drive improvements as well as quality improvement projects, but just changing accessibility. If it turns out that one region has less good uptake, for example, of transplant referrals, is that because of geography or because of other things? And then we can actually use this in real time. We have report cards that actually go to every health authority and are shared provincially for the renal programs and the executive directors. And so it's a very good example of how we started out anonymizing, but then we said, this is silly, we're all in this together. So we no longer anonymize. You can see every region, every hospital, and people are aware of what's going on. I didn't show any graphs, but one of the things that we discovered is from 2022 to 2025, there was a 50% reduction in vaccination of the most vulnerable patients who are on dialysis and transplant. And so we created a real-time change in the way that we actually started talking to people about vaccination. And we now have data that demonstrates in 2026 with a simple education intervention that we actually increased vaccination rates up again in this group. This is probably the thing that happened a long time ago, which really helped everybody believe how important data was. And this was solving a mystery with provincial data. One person developed it just serendipitously. We discovered that this person came to one unit to get dialysis before a transplant, and her platelet count dropped. That put her at risk for bleeding. And then we started to call around, and it turned out that in every health authority, they had noticed a couple of patients with this lower platelet count, which is quite dangerous. And so we sent with one patient and then a couple of other case reports, we actually then collected the data because we had all the dialyzers, all the patients, all their blood work, all in one system. And we were able to demonstrate that we took all those special dialyzers off. We looked at the platelet counts before. We then reintroduced them and could demonstrate that in those places in people that use the electron beam dialyzers, the thrombocyte, the low platelet count went up again. And so you can imagine I was very popular with the dialysis company as I had to go and speak to their executive directors because this got published in JAMA, which is a very high impact journal. But it was a really great demonstration of because we had the totality of data, blood work as well as dialyzers, et cetera, and did this natural experiment essentially where we stopped and then reintroduced, we were able to demonstrate and solve a mystery, which then it turned out that other places like Alberta had also been observing, but with one-offs and no communication and integration, nobody could figure out what was happening. Another example is the BCGN registry, where people come for a kidney biopsy. Glomerulonephritis is a relatively rare disease, but importantly, we need to understand the outcomes of people, no matter where they are in the province. People are followed over time, both with pathology as well as medications, as well as lab data. That's all integrated as well. And we've created a BCGN registry with all these data linkages, including long-term outcomes. And why is that important? Because as time progresses, we now know more and more about these diseases, and we now have medications which are very helpful to treat these medications. But if you don't know who has them and where they are and what their outcomes are, you don't have a way to argue with people that fund the medications to actually ensure that we get them. So now we actually have very powerful data that says that the risk of kidney failure is quite high, and the different diseases, which you can't read, and it's not the point of this, are different. And so when we have to inform a strategy for long-term follow-up, access to drug therapies, and then demonstrate accountability back to the funders of these drugs, we're able to do so because we have this longitudinal data. Again, integrated from a number of different sources, but working with and for the people that need it. And just to conclude, I thought one of our projects that we have in CanSolve, which is a pan-Canadian network, the largest ever funded that we're aware of internationally, for people with kidney diseases, again, patient-informed, and people want to know what their real risk is of kidney failure after they have a cardiac procedure, because the cardiac surgeons will tell you it's 50%, but that's not true, and it scares people, and then they don't get this procedure that they really need. So what we did, and again, I'm not sure how well this projects, but basically we did a risk prediction tool using Alberta data. We derived the data in Alberta and we validated in British Columbia so that we actually looked at what the true risk of kidney failure requiring dialysis was after cardiac interventions. And then using an implementation and again, patient-focused decision aids, looking at predicting death, dialysis and a recurrent MI from the real-world data, we're now doing a discrete decision experiment and developed a decision aid that we can now use so we can properly inform people what the true risk of having another cardiac event is versus truly going on dialysis, balancing their values and preferences as well within the decision aid. And so I thought a very good example of using data to create the true information that's relevant not to Kaiser Permanente in the US, but rather really to Canadian data, and then rolling it out in a way that's meaningful with patients and their families and the care providers. So that was a bit of a whirlwind, but just an example of both a bespoke information system that understands that you need to get the data from numerous sources to put it into a meaningful form to inform best practices and inform decision-making, and how we can actually use data to drive research questions and answer things within the network.